And I would ask Professor Zofia Nawrocka, who will discuss the inverted flap technique in atypical full thickness macular holes.
Ladies and gentlemen, I am happy to be here with you. First of all, I would like to thank Professor Binder, Professor Finchung for inviting me to be here with you. My standard technique in all cases of macular holes, and I will focus in this presentation on atypical ones, is always the temporal inverted ILM flap technique. It's a modification of the original one. After staining with membrane blue, as you can see, I peel the ILM only from the temporal side of the fovea, and then cover gently the full thickness macular hole. We already published in a prospective comparative randomized study that the temporal inverted ILM flap technique is non-inferior in regard to visual acuities and the closure rate when compared to the original inverted ILM flap technique, published by our group in 2010. A big advantage of the temporal inverted ILM flap technique is saving the retinal nerve fiber layers at the nasal side of the fovea. But additionally, we published recently that it saves some vessels in the deep fovea vessel layer. You can see that there are some disturbances of those vessels in Swepser's OCT angiography in the peeled area, not visible in the area when the ILM was left intact. Now coming to the atypical cases of full thickness macular holes, starting with the myopic full thickness macular holes, it was the first indication besides large long-standing macular holes to use the inverted ILM flap technique. Kuriyama, our group, and others confirmed it is successful, and we can give our patients an improvement of the visual acuity with this method. We must understand that macular holes in high myopia have slightly different etiopathogenesis from idiopathic cases. Besides traction, elongation of the eye and chorioretinal atrophy play a role in the development of full-thickness macular holes in high myopia. A recent meta-analysis compared papers presenting the technique originally described by our group, namely the inverted ILM flap technique, the cover technique, with the insertion of the flap inside the macular hole. And it occurred that in macular holes without retinal detachment, both the closure rate and the improvement of visual acuities were higher in the cover technique. So we should not put the ILM inside the hole in those cases. The more demanding cases of macular holes coexisting with retinal detachment give us the same results, and it's especially important in regard to visual acuity. As you can see that it is the visual acuity is significantly better in the group where the ILM was only gently positioned on the top of the fovea. Another rare indication for the inverted ILM flap technique is the Coats disease. In the literature, I found only several papers for the last 60 years on this rare complication of the Coats disease. And 2 of them reported that the closure process might take even up more than 6 years in order to close the macular hole. Those patients are usually much younger than that we meet during idiopathic macular hole surgery. And as it is obvious in younger patients, the removal of the posterior hyaloid might be much more demanding. The structure of the ILM in Coats disease is also slightly different from idiopathic cases. Because of that, you can see that I peel the ILM not only temporal, but from the superior side of the fovea in order to cover the macular hole. The closure process takes also much longer. You can see that the fovea is slowly closed during more than 1 year after surgery, achieving final anatomical and functional success. Another rare indication are macular hole coexisting with age-related macular degeneration. There are only several studies. Most of them report that visual acuities and the closure rate is lower than in idiopathic cases. Because of that, we started to use the temporal inverted island flap technique in full thickness macular host, which coexisted with dry age-related macular degeneration. In this movie, you can see an eye with many soft drusen, in which we performed the temporal inverted island flap technique. And of course, the cover technique in this situation. This report is already published, and we noted that the anatomical success is almost 90%. It's with this first surgery, and it's slightly less than in idiopathic cases. The final visual acuity in this group was 0.5. But what is important, there is no significant correlation between the macular hole diameter and final visual acuity, and that it is different than in idiopathic cases. Probably because the underlying disease, age-related macular degeneration, influences also the final visual acuity. But there is a strong correlation between visual acuity before surgery and the final visual acuity. Interestingly, we observed new drusen in 7 eyes in our study group, and they decreased in size in 4 patients. Such a disappearance of drusen after vitrectomy was already described by Holtz, Lee, and others, and it was attributed to the phagocytosis of drusenoid material after the removal of the posterior chyaloid. In one case, we observed that geographic atrophy developed 12 years after successful macular hole closure. And in also one case in our study, we observed that there was a choroidal neovascularization years after closure of the full thickness macular hole. It's a very rare complication described in more than 200 cases in the macular hole study group. And those cases can be normally treated with anti-VEGF. Another rare situation are macular holes coexisting with age-related choroidal atrophy. Age-related choroidal atrophy was first described by Spady and might be differentiated from geographic atrophy in autofluorescence, where it shows no changes. Those patients have preserved the distance visual acuity with decreased near visual acuity. What about these patients? He encountered spontaneous closure of the macular hole without any surgery, but almost 1 year later developed choroidal neovascularization in the eye after spontaneous closure of the full thickness macular hole. Here you can see Swepser's OCT angiography of this case of age-related choroidal atrophy with later development of CNV. Another rare situation is the development of full thickness macular hole during the treatment of active choroidal neovascularization. The problem, the question we might ask ourselves is whether we should perform surgery, as obviously it might have some influence on the washout time of the anti-VEGF, and this patient was continuously treated for 10 months for choroidal neovascularization. Because of these questions, we waited for 3 months until we decided to make vitrectomy. During the meantime, we thought about the washout time of anti-VEGF, and based on our studies in endophthalmitis and on the DRCR network that described there is no problem with further anti-VEGF treatment after vitrectomy, we decided to treat this patient. And here you can see a video. This is a patient treated for 10 months with aflibercept, with choroidal neovascularization, some underlying drusen. And here also we performed the temporal inverted island flap technique, taking the smallest amount of vitreous out of the eye, performing only core vitrectomy, and making a small peeling on the temporal side. 1 month later, we observed that the macular hole is closed, and until now, the patient is treated every 1 or 2 months with aflibercept, and the final visual acuity is quite satisfying. Another rare indication and rare coexistence of full thickness macular holes is diabetic retinopathy. What is interesting and a little different from idiopathic cases that even in non-proliferative diabetic retinopathy, in most cases, the results are worse than in idiopathic eyes, and that we observe some small persisting photoreceptor defects many months after surgery. We also observed in about 30% of eyes some hyperreflective remnants of the ILM on the top, on the surface of the closed macular hole. Of course, we were a little worried about the possible proliferation in those cases, but we performed another study on idiopathic eyes and published it in Retina with longer observation time, and none of those cases with this hyperreflective remnant presented to you by the arrow, none of them developed to any proliferation afterwards. So such an appearance might be observed also in diabetic retinopathy. Proliferative diabetic retinopathy coexisting with full-thickness macular holes shows us an appearance maybe slightly similar to that occurring in high myopia. That means that the minimum to maximum diameter ratio, which is in idiopathic cases 1 to 2 usually, that is in myopia, and in proliferative diabetic retinopathy, rather 1 to 10. So we encounter detachment of the retina and a very big maximum diameter. Here you can see surgery performed in those cases. In some of them silicone oil must be used. In this case, we peel the ILM from the further periphery, as this is an eye which developed a full thickness macular holes with fovea detachment after earlier vitrectomy. So you can see we had no ILM in the fovea. We had to perform a pedicle flap. It is some modification of the autologous ILM flap transplantation. You can see it can fly over. You have to position it. We usually use viscoelastic material to do that. And as you can see in this slide, the closure process in proliferative diabetic retinopathy is prolonged. It might last several months. You can observe during that time some subretinal fluid that resolves spontaneously from itself, but it takes a longer time than in idiopathic cases. The maybe most interesting and most rare indication for the inverted ILM flap technique does not concern the macular holes, but the optic disc pit. And in order to treat maculopathy in the optic disc pit, we should push the ILM inside the optic nerve. As a conclusion, I would like to state that the temporal inverted ILM flap technique is non-inferior to the original inverted ILM flap. It should be always gently laid over the surface of the full thickness macular holes. Pushing inside is only possible in optic disc pits. And we can close with this technique full thickness macular holes coexisting with AMD, high myopia, non-proliferative or proliferative diabetic retinopathy, or Coats disease. Thank you for your attention and hope to meet you live in the next meeting.
Thank you very much, Zofia. We now have the time to discuss your presentation. I really enjoyed your difficult cases. We have already 2 questions, which I would like to read to you. Number 1 is, have you noticed any correlation in the rate of macular hole closure and type of surgery, combined phaco, pars-planar vitrectomy, or phaco with subsequent pars-planar vitrectomy 1 month?
First of all, thank you very much once again for the invitation. It's very nice to be with all of you here. And coming to the question, I do not use combined phaco-vitrectomy in all cases. It's not my routine. I do it only if the patient has significant cataract, and I did not observe any correlation. I don't think that the additional cataract surgery has a negative or positive influence on the final outcome of the macular hole surgery. In fact, we usually observe cataract formation in the first year after surgery. So it might be reasonable in some cases surgeries to make it combined.
Okay, thank you. We have another question.
Yes, and should I come to the next question?
Yes, please. Question number.
Yes, I can.
Can you hear me?
Yes, now I hear you good. Now it's okay.
So do you no longer place the inverted flap into the hole? I think you have already answered this during your talk, but perhaps you can repeat this again.
Yes, thank you. That's an excellent question. We never did place the inverted flap inside. It was somehow probably misunderstood, but the original idea of the inverted ILM flap technique from the first study was just to cover it gently, to peel the ILM and to put it over the macular hole. We never did pushing inside, but some surgeons did. And because of that, there are several studies comparing the pushing technique and the covering technique. The covering is our original one. And indeed, it is associated with better visual acuities. I presented that from a comparative study in myopic macular holes, but it was also confirmed in idiopathic cases. So it is better to leave it on the top of the fovea than to push it inside.
Thank you. I have a last question. Are there still cases, Zofia, do you hear me?
Yes.
Are there still cases where you do routine vitrectomy, ILM peeling and gas and nothing else?
Sometimes in young patients with very small macular holes, I do just ILM peeling, but in general, in 99% of my surgeries, I use the temporal inverted ILM flap technique.
I have also one question to Zofia. Thank you very much for your presentation. It's very nice to see you and during this webinar. Certainly temporal flap technique has more advantages. Most of all, these are the anatomical sparing of the nasal part of the paranasal, nasal to macular hole. But I had one case which I would like to share with you. I used this was idiopathic macular hole. I used a temporal flap, and the hole was closed, but within 1 month, it reopened. And on OCT, I could see that the temporal flap went away, and the temporal edges of the macula were attached, but the additional, I explained this, so additional gliosis of the ILM on the nasally to the macular hole created the elevation of the nasal rim of the macular hole. Only nasal was elevated. So I did the second surgery, and I did nasal flap because I lost already temporal flap. I did nasal flap, and I was successful with this kind of surgery. Have you seen such cases that the ELM changes of the remains of the ELM induced the new hole after the closure?
That's a very interesting issue. In fact, I think that all failures of the inverted ILM flap technique are associated with the coming back of the ILM, with repositioning of it. They are extremely rare, but they might be observed, and we also observed such cases in the past. I usually do as you did. So I take the ILM from another part of the fovea and close the hole in the second surgery with a very similar attempt.
Thank you very much. Thank you very much.